Hello and welcome for this session on ARDS update, the most important topic discussed in critical care medicine, and we are going to highlight some practical aspect and see how the ARDS treatment developed from 1967 till 2025. That is a long 50 years of research on acute respiratory distress syndrome. So this is the most important slide in the history, which shows that in 1967, Ashbach and team was the first to report 12 cases of dyspnea, tachypnea, hypoxemia. Mind you, at that time there was no pulse oximeter, so refractory cyanosis was seen. They identified that these problems were there with decrease in the lung compliance of the patient, and out of these 12 patients there are almost staggering 60% mortality, and in post-mortem they defined that these patients had diffuse alveolar infiltration, something like a neonatal hyaline membrane disease. So the case series is also important for reporting, and they went to the various American journals to report these cases, and mind you, most of the journals initially refused to dismiss these cases as the cases of left ventricular failure with pulmonary edema. But they tried to convince them, and they found that this was something which is non-cardiogenic pulmonary edema, and ultimately in Lancet these cases were published, and the terminology was kept as a adult respiratory distress syndrome. Later on they converted it to acute respiratory distress syndrome. So the journey started from 1967, identifying these cases, and then in 1988 the severity scoring was kept to identify which patient has more mortality, and the Murray and colleagues worked in this, and they took the 4 important parameters to objectively define the severity. These were the requirement of positive end expiratory pressure, the respiratory system compliance, the radiographic finding showing how many of the quadrants are affected by this ARDS, and the level of hypoxemia. And all these 4 parameters they scored it, and the score more than 3.54 had high mortality. So this was the lung injury score, which was also later utilized in various research studies, and now today also we use lung injury score or Murray score for initiation of ECMO in certain patients. Then came in 1994 the European American Consensus Conference definition, and then they defined something, acute respiratory distress syndrome, which occurs in acute onset, so focused on onset, that within 7 days if the patient develop hypoxemia, and they use the PaO2 by FiO2 ratio on the ABG as a criteria to define acute lung injury and ARDS. So they have 2 terminologies: acute lung injury PaO2 FiO2 less than 300, and ARDS patients with POF ratio of less than 200 with bilateral infiltrate and no signs of pulmonary edema in the form of, like, bedside there was no S3 sound, there was no evidence of vascular pedicle width was normal, there was a normal BNP levels, and these are all the bedside tools which we can use to define whether it is a cardiogenic or a non-cardiogenic pulmonary edema, and of course pulmonary capillary wedge pressure of less than 18 in such cases. So this was the American European Consensus Conference definition, which was later defined by Berlin in 2012, and they removed the terminology. So this, see how the ARDS definition kept changing for better diagnosis and better treatment, and they found that the definition containing ALI misses the patient, and they removed the terminology acute lung injury. They defined the 3 categories of ARDS depending upon again the PF ratio They defined it mild, moderate and severe, where PF ratio of 200 to 300 was mild, 100 to 200 was moderate, and less than 100 severe. And also the treatment was defined like non-invasive ventilation could be tried in mild and moderate category. They also kept the 1 week definition of clinical insult for the defining of ARDS and PEEP level of more than 5 centimeter of water. Later on, as we started using the bedside lung ultrasound, the need for HRCT or X-ray was removed, and even with the lung ultrasound, you can define the haziness, bilateral B lines, non-cardiogenic pulmonary edema, and you can include and diagnose this patient as with other criteria of PF ratio and PEEP as a cases of ARDS. After COVID, we noticed that there was increased use of pulse oximeter and increased use of high flow nasal cannula. So to broaden the definition in resource limited setting, they identified that the SpO2 FiO2 ratio, which is a non-invasive way of identifying the hypoxemia, of course, the most important is the saturation should be less than 98%. We know that in oxygen dissociation curve, the above 98% is the flat part of the curve. So SpO2 less than 98% with SpO2 FiO2 ratio of around 315 corresponds to PaO2 ratio, PO2 FiO2 in ABG around 300, and SpO2 FiO2 of 235 corresponds to the PF ratio of 200 on ABG with ultrasound imaging and use of high flow. So this was European consensus guideline, ICM guideline 2013. And now where we have reached in 2024 or 25, we have started using the global definition of in which we can use SpO2 FiO2 in resource limited setting, patient on the high flow rate of more than 30 liter per minute or a high flow nasal cannula, and depending upon the SpO2 FiO2 ratio and insult. Also, we have increased the duration after COVID from 1 week to 2 weeks. We have seen that in COVID it went up to the 2 weeks. So this new global definition and this whole history of development of ARDS helps us understand, and also we are kept refining and kept improving, because the most important is the delay in the diagnosis, and to improve our diagnostic sensitivity, this new global definition of 2024-25 is the ideal to diagnose and treat the ARDS early. Now, what are the implications of these new definitions? So these 3 patient cases clearly defines you that how the ARDS can be categorized. So if I start with the 68-year-old male, you can see the X-ray. He's on mechanical ventilation. He's having a PF ratio of 150, and it is definitely a moderate ARDS patient. Is a typical patient if we consider as a patient with a Berlin definition with sepsis, septic shock, and acute hypoxemic respiratory failure. Come to the next patient. If you see this patient, this is lady on the high flow nasal cannula. This COVID-19 pneumonia worsening in past 6 days. And here if you take SF ratio, that is SpO2 by FiO2 ratio is less than 200, is again she, as per the new global definition, we can include this non-intubated patient also as a ARDS and put our regular treatment protocol in that, and we can identify early. So this is non-intubated ARDS. This third patient is abdominal sepsis with gram-negative bacteremia and small under-resourced hospital where without blood gases and radiograph. In such situation also you can identify with, here you can see the B lines here on the ultrasonography, and SF ratio of less than 200 in resource limited setting. This is a new category of global definition of ARDS where supplemental oxygen with 15 liter per minute and SF ratio of 142. This is ARDS in a resource limited setting. So this is the implication and development of the definitions we should understand. So what are the landmark trial and practice changing papers in ARDS and how the mortality has been coming down, we'll see. And the most important, if we are discussing ARDS today, the most applicable, which was in 2000, the ventilation with lower tidal volume ventilation compared to traditional tidal volume The NEJM paper of 2000 is must read for all the students, in which they had a sample of 861 patients. The trial was stopped early because they found very good results in the patient with 6 ml per kg body weight of tidal volume and increased mortality in those with 12 ml per kg. There was significant decrease in mortality. So Ashbag reported 60%. Here the mortality was 40% and reduced to 31% with low tidal volume ventilation and keeping the plateau pressure at 30 centimeter of water, less than 30 centimeter of water. These are the protocol. You should go through this paper and you will see the PEEP and FiO2 ratio. Importance of PEEP is very important to keep the lung open and prevent the atelectatic injury, get the best optimum PEEP to get the good oxygenation. And all the time in low tidal volume, the plateau pressure was kept less than 30 and you regulated the respiratory rate from 6 to 35 depending upon the pH. So lung protective ventilation with low tidal volume ventilation, optimum PEEP is the most important strategy, which itself reduced the mortality from 40% to 31%. This paper also included they measured the IL-6 level as well, and they found that IL-6 level on inflammatory marker was much more in the higher tidal volume case, which was not much highlighted, but now in later in COVID studies we have done a lot of studies on this inflammatory marker. So this is the textbook of critical care medicine, and this is what we should have bedside, and we should follow this, because in ARDS patient most of the time looking at the weight or actual body weight of the patient, the tidal volume was delivered, especially in obese patient, may be much higher. So every patient you should take the length of the patient. With this we have discussed in earlier mechanical ventilation series also. You have to do bedside predicted body weight, and this doesn't require the weighing beds. This doesn't require any hi-fi weighing beds. This require you have to calculate the height of the patient in inches, and you have to calculate, and males 50 plus 0.9 times height in centimeter minus 152 will give you the predicted body weight. That is what is required to set your tidal volume. And similarly in female 45.5 plus 0.9 times height in centimeter minus 52. Initial tidal volume will keep 6 ml. You will check plateau pressure every 4 hours. How do you check plateau pressure? The inspiratory pause will give you the 0.5 second will give you the plateau pressure, and it should be kept less than 25 or less than 30. If it is going more than that, you can decrease on your tidal volume. Similarly, you have to make changes in the respiratory rate and decision regarding your infusion of soda bicarb, depending if the pH is less than 7.3 and you achieve the maximum RR, still you are not achieving that, you can consider bicarbonate infusion. And you have to keep the PEEP and FiO2 ratio here is given. It approximates the FiO2 into 20 is what is a normal PEEP initially to start with. Like suppose if you have a FiO2 requirement of 60, you can start with 0.6 into 20, that is around 12 centimeter of PEEP, and you can identify the this is a practical way of keeping the initial PEEP. Then of course the other studies came which showed that the fluid management, you should not drown your patient in fluid. So IV fluid management on day 3 patient should be negative. Initial resuscitation is acceptable, but the patient has to be kept euvolemic, and of course no other organ perfusion you should see, and try to keep conservative fluid management in a patient of ARDS, and if appropriate you can use diuretic and fluid. Coming to the oxygen target, though this initial study showed the oxygen target in ARDS from 55 to 70, but we know that this was challenged recently in LOCO2 trial, where they found increased incidence of mesenteric ischemia if you keep this low oxygenation target, and they gave the target from 90 to 110. So maybe somewhere between 70 to 90, we don't know. So that is not to be very low on oxygenation target as per the new emerging data. Coming to another landmark trial which every ARDS patient we do, and we should know this, PROSEVA trial, prone position in severe acute respiratory distress syndrome. I'll urge students to go and read in detail. It's what a multi-center prospective randomized controlled trial which enrolled 500, almost 466 patients, and the prone ventilation was given for 16 hours. What was the criteria? All the patients who could not maintain oxygenation, PF ratio less than 150, was given the prone ventilation, and they saw a significant reduction in mortality. So from mortality reduced from 60 to 40% with low tidal volume ventilation, it reduced further to 16% with prone session. So this had a very good recruitment maneuver. It is one of the good recruitment maneuver, homogenization of oxygenation and impact on mortality. So ProSiva trial showed us that if we get a PF ratio less than 150, we should offer our patient, we should get the prone ventilation. In moderate to severe ARDS, so these are the strong recommendations of low tidal volume. Please calculate the predicted body weight and calculate the 6 ml per kg. Organ crosstalk is there if we give high tidal volume, and IL-6 is the one which causes biotrauma. Prone positioning for PF ratio less than 160 is no doubt the benefit in ARDS patient. Coming to the PEEP, we require PEEP to keep the alveoli open, but yet we have to identify the best way to keep the PEEP. I told you FiO2 into 20. So Fi fraction of FiO2 in 20 is the approximate PEEP which you start. It's a concept of open lung concept. We don't want the alveoli to repeatedly close and open, and that itself leads to atelectatic trauma. Of course, the PEEP, high PEEP may have complication with heart-lung interaction and hypotension. You should keep a watch on. What is strongly discouraged? Recruitment maneuver are strongly discouraged. So initially 40 centimeter of water, 40 seconds, and keeping the alveoli to make it open is strongly discouraged with emerging evidence. So there is no role of recruitment, short duration of high inspiratory pressure to open up the atelectatic alveoli. It causes a lot of barotrauma and it causes hypotension, and these transient maneuvers are strongly discouraged. Spontaneous breathing during ARDS. So it's a new concept where they definitely we have to keep conscious sedation, not very deep sedation in a moderate ARDS patient. In severe ARDS patient, initial 48 hours you may require neuromuscular blockade, but later on you should come down on your sedation to prevent diaphragmatic atrophy, to improve the VQ match, and also the need of sedation will be reduced. So your other complication of critical illness, neuropathy, myopathy will be prevented. So the sedation in ICU is an art. Of course, in severe ARDS, initial 48 hours, there is study also backup which shows that you can give 48 hours of neuromuscular blockade in patient with PF ratio less than 100, but other cases you should titrate your sedation as per the scale which you utilize in your ICU. What are the risks of low sedation? Of course, there is the desynchrony, anxiety, increased oxygen consumption, CO2 regeneration. You have to balance these things, and ventilator asynchrony. So this causes more harm. So you should have ways to see the synchrony, read the graphics. Go to my lecture on graphics. You will know how to identify the ventilator synchrony and adjust. And of course, if the patient is also on the non-invasive ventilation, also you get something called as spontaneously induced lung injury. So don't think that the patient with NIV or high flow cannot get a lung injury, ventilator induced lung injury, because of the high driving pressure of the patient. There was swing in the transpulmonary pressure and pulmonary edema, and this patient itself can develop a SILI, that is spontaneously induced lung injury. That can be a possibility. Neuromuscular blockade, as I already mentioned, is recommended in early treatment. In trial it has shown that you should use it less than 48 hours, of course with the patient with severe ARDS. Coming to new modality, which after in COVID series we have seen VV ECMO. We know venous ECMO is a very good strategy. Of course, low certainty of evidence at present because of the availability, but you should choose the right patient. VV ECMO is now recommended in select patient with PF ratio of less than 80, Your Murray score, which we discussed, more than 3.5, 3, and pH is less than 7.5. Your PaCO2 is more than 60, despite optimum mechanical ventilation, which we discussed: low tidal volume, lung protective ventilation, prone ventilation, adequate neuromuscular blockade, fluid conservative management. Everything has failed in 6 hours. You should consider this patient for VV ECMO, and it's a strategy in these other indications which you should remember. Steroids, controversial of course, but in COVID we have seen that administration of steroid is recommended, but you should select your patient, whether it is dexamethasone, whether it is methylprednisolone, whether this patient has underlying COPD, whether this patient, what is the dose, timing and duration. We are not clear on that. 8 milligram was used in the per day low dose steroid. In sepsis also we use steroid, low dose steroid for vascular for the hemodynamic stability purpose. So administration of steroid is a personal clinician decision, not a regular in all the patients. You should select your patients who will benefit from steroids. Look at this interesting graph. So where are we heading? So this 50 years of journey, if we see from the 12 cases which are reported, there was almost 58% mortality, which came down after the ARDS net landmark trial, which you all should read. Low tidal volume, and the mortality reduced to somewhere around 38% or 30%. And then it further with ProSiva trial, which shows the prone ventilation, it further reduced the mortality to somewhere around 24%. And we are heading towards recovery trial with steroid in appropriate patient, immunotherapy and immunomodulation. It reduced further to 20%. And what I am seeing further is with the use of appropriate ECMO and other facilities, and identifying the patient early and using the global definition, we will definitely make a dent in the ARDS mortality and bring it down further below 20%. This will be very good to achieve. So this is the 50 years of journey and how we are moving towards the success. There are areas of controversy. One blanket cannot fit all, we know in critical care. So personalizing mechanical ventilation. So we are getting the parameters like driving pressure, mechanical power. We are getting new and new parameters to personalize the mechanical ventilation in such ARDS patient. We will be soon be able to find the best select method of PEEP, because you know the extra PEEP is detrimental, lesser PEEP is again detrimental. We are using most of the time driving pressure, and various studies that driving pressure less than 12, that is plateau pressure minus PEEP, is ideal for the keeping the PEEP. If you have a facility, you can use transpulmonary pressure by monitoring by esophageal manometry and titrate your positive and expiratory pressure. So positive and expiratory pressure is a very good parameter, good to set adequately in personalized in these patients. In obese patient, of course, TPP is low. You have to keep a higher PEEP, which we know. So PEEP and recruitability, again, you should know the what is your structural ARDS. So whether it is focal ARDS or a diffuse ARDS. So you have to see the various phenotype, hyperinflammatory, hypoinflammatory. So this is a new way of defining and moving ahead with the treatment. We know that the diffuse ARDS will respond better with the recruitability, prone ventilation PEEP, whereas the focal ARDS may have more harm because it's a focal. So you have to identify where your patient is. This is EIT monitoring, electric impedance monitoring. If you have a facility in tertiary care, it gives real-time lung expansion and of the both the lungs, and you can actually titrate your PEEP according to this non-invasive modality. What is in future? This is the most important slide. You have to identify your ARDS patient through this lens of 12 parameters. So first see whether it is a homogeneous, heterogeneous, focal or diffuse. Look for the biological heterogeneity, whether trauma caused it, whether the pancreatitis caused it, whether the response to the sepsis caused it. That is the biological phenotype of biological heterogeneity, whether it is hyperinflammatory, hypoinflammatory, functional heterogeneity, Then temporal heterogeneity, at what time the patient has come to you, what are the therapies benefiting, specific therapies benefiting certain times, such as prone ventilation, when you will start. Early the proning is better if PF ratio less than 150. What is the time for introduction of steroids? Late steroid will be detrimental. Targeted ventilation strategies, I told you, you have to identify the predicted body weight and you have to keep the tidal volumes, low tidal volume with your driving pressure around less than 13. Biomarkers are important to identify whether endothelial damage. We have seen in COVID there was endothelial damage, and even heparin or low molecular heparin was important in part of treatment, and to subphenotypes as hyper and hyperinflammatory, which will respond to steroid therapy. Personalized approach is important, and monitoring and imaging techniques, newer and newer, we are getting ultrasono and we are getting the EIT, tomography, electrical impedance, and this will definitely make a dent in the treatment in future, and we will be able to bring down the mortality to less than 20%. Thank you very much for your patient listening.